of the skills pavilion. Our main objective in this module is to give you a set of skills in assessing a patient with the symptom of vertigo. So, to this end, we have set up certain short presentations, and we have positioned the skill demonstrations and skill practice sessions at strategic points, so that you will get to do the hands-on as well. So we invite you to feel free and relaxed and just follow along. And if you have any questions, you can ask at the end of the Q&A. If you have a very learning question you want to ask, you can always attempt. And first of all, let's turn your attention to the folder that you received when you came into the session. Is there anyone who doesn't have a folder? So the first page we're going to see in the folder is our objectives. So I have already given you our general objective. These are our 4 specific objectives. We want you to know the terms, the definition, what vertigo really is, what it isn't. And also, secondly, we want you to understand the basic anatomy, the physiology, the fundamentals behind the patient with the vestibular system, so vestibular system anatomy and physiology. And then we want you to be competent in taking a history and examination in a patient who presents with acute severe vertigo, and also multiple episodes of vertigo. The 4 skills that you want to you take home from this session is 1, distractless smooth pursuit and eye movement checking, head impulse testing, number 2, 3, visual fight test, 4, the engagement. Now, after the specific objectives page, you will find, secondly, a collection of 4 sheets. We have reconstructed each and every skill into a checklist. So it's easy for you to follow and it's easy for you to practice. So it will be very clear and reproducible and consistent. Thirdly, you will find a sheet giving a complete overview of a patient, history taking, examination and investigation of a vertigo patient. So it's very detailed. We don't have time, no intention into going into details of the findings in this session, but this is given as an overview or a reference or a map. Fourthly, you will find 1 minute feedback. It just only takes 1 minute. It's a validated the skill assessment. So we want to take a minute and then fill that and give us analysis. There are 2 other special notes about this section of skills pavilion. First, we have created an online module for this. So at the end, you will be given a link to the module. So you can register yourself, and our presentations, our skills, the reconstructed checklist, all the details, videos, all will be made available online. So you can access them anytime you like and at your convenience. So you don't have to rush to take any points and notes on it. You are free to do whatever you like. But that will be available. Second, second interesting thing is we are going to live telecast or broadcast this as a webinar. So it will be again available in that online module, and at the end there will be a YouTube video which you can watch leisurely and correct yourself about the skills or whatever. So that's all being done. So with the introductory remarks, let's move on to our program today. First of all, we are going to start with the basic introduction to fundamentals of anatomy and physiology of the vestibular system. Right. So without basic fundamental knowledge, it's difficult for us to develop clinical skills. That's why we start with anatomy and physiology as the first thing. If you look at this diagram here, this shows the intricate relationship between the vestibular system, somatosensory system, and the visual system to bring about balance. So what is balance? In biomechanics, balance is the ability to maintain the center of gravity, the level vertical line going through the center of mass with minimal postural swing. So for you to get that perfect balance, these systems have to work in perfect order. So today's presentation will be focusing mainly on this, that is the vestibular apparatus, because we don't have time to go into all the other somatic areas. So it's a vestibular related module. I will be touching on those both in this short presentation. I will be giving you an overview of the gross anatomy, and then the two vestibular sensors, crispity and maculae, how they are located and what their function is, and the neuronal connections between the vestibular system and the other systems that we talked about, and specifically about these two reflexes, vestibulo-ocular reflex and the vestibulo-spinal. Okay, so with that objectives in our mind, let's move on to the anatomy. So here's a familiar diagram. It's a very familiar diagram for all of us. We have three components in our ear. We have the outer ear of the tympanic membrane, middle ear cleft here, and the inner ear. So our subject of interest today is the inner ear. So inner ear has three semicircular canals. They are in orthogonal planes in 90 degrees to each other, and we have two sets of semicircular canals. So we are working coordination between the sides. For example, the lateral horizontal canal on both sides, superior of the left with the posterior of the right, and vice versa. So they send information in that coordinated fashion, and they are in a 90 degrees angle. So this is important because if there is a problem of this organ, their plane of stimulation is in an angle. So vectorial sum of the affected semicircular canal will determine the vertigo. So it's going to be a more torsional vertigo rather than a pure horizontal or pure vertigo, depending on the damaged canal. So let's look at the membranous labyrinth. So semicircular canals that we have already shown you in the previous slide has very interesting anatomical feature. At the ends, there is a dilated area. We call that the ampulla. Within the ampulla, there is an organ called cristae. Cristae is a specialized hair cell collection. It is sensitive to fluid movements within the inner ear, and therefore you get angular acceleration information from the cristae because they are angles. So when the head moves, the body moves in angles, with the angular movements sensed by the cristae. There's another set of sensors. We'll come to that in a minute, but let's concentrate again on the angular acceleration. Look at this head here. This is the movement of the head towards right side. So when the head turns towards right side, the firing rate on the right semicircular canal becomes less. So that's because of the fluid mechanics in the semicircular canal. And at the same time, the firing rate on the opposite side becomes increased or worse. So as a result, when the head turns to one side, the opposite side is the most active of the two. So that's the angular acceleration. What about the linear acceleration? So concentrate on this bit now. This is where the utricle and the saccule is located. The difference between the semicircular canals and this bit is that you have these calcium carbonate crystals. So because of the calcium carbonate, which has a mass and the weight for that, it's a gravity sensitive form. When the force of gravity works upon it, there's distortion and there is stimulation of the nerve endings here, and the brain is given the gravity sensitive information by the macula of the utricle and saccule. So both the gravity sensitive information or linear acceleration, angular acceleration, both information goes through the vestibular nerve to the central nervous system. So that's how the information comes to the central nervous system. So when it comes to the central nervous system, from here, these systems, visual, somatosensory, also have to work with the vestibular information. Otherwise, you won't be perfect balance. So how does the nature has achieved that? By having a complex interconnections between these systems. It's a very complicated diagram, but let's take part of it first. This bit. So here you can see, here you can see the first part where you get the information from the semicircular canal alveoli, utricular macule and saccular macule to the vestibular nuclear complex, which is situated in the pontomedullary junction. Here we have 4 groups of vestibular nuclei, superior, inferior, medial, and lateral. So that's the first bit. So the information is there already, the central nervous system. Now we need to coordinate. So how do we do that? This is the second set of connections. From the vestibular nuclei to the abducen here, phyllomotor nucleus, and the cochlear nucleus. There are complex connections. So that vestibular and ocular muscles, the movements, are interrelated. And we'll come to that in a moment. It's very important in vestibular ocular reflex. Let's take this bit now. This is where the nuclei sends the information down to the spinal cord, to the spinal muscles, motor muscles, limb muscles, and this is called the vestibular spinal reflex. The information is carried through the lateral vestibular spinal tract. So, I have demonstrated the vestibular reflex pathways and vestibular spinal reflex pathways, important for balance. But let's concentrate a little bit more on vestibular ocular reflex, because that's a very important aspect, and we're going to get that in a minute in our skill session. Just follow this red dot here, that is the excitation. This first thing, from the vestibular nucleus stimulation, it goes to the contralateral abducen nucleus. Contralateral abducen nucleus. As a result, the muscle which is elevated by the abducen nucleus, the lateral rectus pushes the eye away. And at the same time, via the medial longitudinal fasciculus, contralateral medial rectus is also stimulated. So again, the eyes moves away. So this is how the vestibular ocular reflex works, to keep the target foveated right onto the retina without letting it slip away. And also this shows the vestibular stimulation from the right side, or whatever side, the opposite side will be the eyes being moved. They're forced away from the vestibular nucleus. So that will also explain, if there's a problem with this particular side, the eyes will tend to drift towards that side with a corrective jerk away. Towards this side with a corrective jerk away. So the nystagmus is going to get away from the vestibular vision. Is that clear for you? So I think my short presentation was concentrated on the gross anatomy and the vestibular sensors, the vista and maculae, and how the neuronal connections are there, and how the vestibular ocular reflex and spinal reflex are brought about. So with that background knowledge, let's move on to clinical stuff. So very important than interesting than the fundamentals. And what we want to do first is to assess a patient who has an acute single episode, and then we'll practice 2 skills with that. Then we will move on to multiple episodes and practice another 2 skills. So that's the plan. So over to you, Ravindra, to discuss acute vertigo.
Good morning. I just start with some practical definitions and clinical approach very briefly. Then we move on to assessing a single episode, and then we'll see how we acquire skills of a single episode. Okay. As usual, I would like to start this talk with this theme picture taken from famous Alfred Hitchcock movie named Vertigo. Simply because it shows what vertigo is, something like that. Vertigo can be defined in different ways, but the practical definition would be an illusion of either oneself or the environment rotating. Please note the term rotation. Vertigo, when defined in this way, is a very reliable symptom of a vestibular disorder. It can be ventral or central. I shall explain the pathways involved there. Dizziness, on the other hand, is defined as an impairment in spatial perception and stability. Therefore, it could represent this equilibrium, imbalance, motion intolerance, oscillopsia, and even vertigo. So, dizziness is an umbrella term really. So, having those definitions at the back of our mind, we will now move on to clinical evaluation. So, when you take a history from a disease patient, we need to sort out two main problems at the outset. First is the nature of the problem. That is whether the patient has true vertigo, dizziness, or something completely else like loss of consciousness. Secondly, the pattern of the problem, meaning now we have three clinically useful patterns in this context, and this forms the basis for our current approach to management of vertigo and dizziness. Patients can have one episode, they can have multiple episodes, and they can have chronic dizziness. Today we will be focusing only on single episode and multiple episodes for you to for us to sort of teach skills. So with that, we'll move on to single episode. Right. Suppose you are seeing a patient in a medical casualty and with the acute severe vertigo lasting 4 hours to days. There is no history of similar events in the past. One single episode, big episode. Acute single episode of vertigo can be due to peripheral pathologies like vestibular neuritis, labyrinthitis, benign, or more serious central pathologies like life-threatening cerebral hemorrhage, brainstem infarction. I hope you know the difference between vestibular neuritis and labyrinthitis. Sometimes getting confused. Any idea? Difference? Lakshan told explain you about the anatomy. Vestibular neuritis is only in the vestibular nerve. It's a neuritis or neuronitis. So it's only in the nerve, therefore it's only vestibular, so they will have only vertigo. They won't have any hearing problem. Whereas labyrinthitis, the whole labyrinth, hearing part and vestibular part is affected, therefore they will have vertigo as well as hearing loss in addition to that. So, and tinnitus also, because tinnitus is related to hearing loss. That's the difference. Okay, again, acute single episode can be due to peripheral pathologies and central pathologies. So, therefore, the main objective is to differentiate these two conditions in this scenario. For that, we need to jump to the targeted clinical examination without wasting any time. Acute peripheral vertigo will have these three features. They will have what's called peripheral vestibular nystagmus. They will have normal eye movements, namely normal smooth pursuit and normal saccadic eye movements. Their head impulse tests may be positive, usually positive. Whereas in central vertigo, they may have one of the central pattern of nystagmus. Their eye movements may be abnormal, and their head impulse test is negative. Mind you that this is there in the website, so you can go to and everything is there. Okay, so we'll see what you mean by peripheral vestibular nystagmus. Peripheral vestibular nystagmus has four main characteristic features. We'll see one by one. Peripheral vestibular nystagmus is supposed to be a jerk nystagmus. That is to say, it has a slow pace and a fast pace. They have constant velocities on their own, slow pace and fast pace, differently. The fast pace usually beats away from the peripheral vestibular lesion. Lakshan has already told you about it. You look at the video clip. Fast pace leads towards left side. So the nystagmus, the side of the nystagmus is defined as by quoting the fast pace. Therefore, it's left beating nystagmus. Left beating nystagmus. The lesion has to be on the right side. The first characteristic. The second characteristic feature is can be explained by Abel's first law Lakshan told you that. Now, the law is that the axis of the nystagmus should match the anatomical axis of the semicircular canal that generated the nystagmus. You know that semicircular canal dysfunction generated nystagmus. But we have 3 semicircular canals in 3 different planes. Therefore, the nystagmus has to be on the direction of the vector of those 3 canal directions. Therefore, in peripheral lesion, you cannot have pure horizontal nystagmus. So what you see is horizontal nystagmus with a very minor torsion comes. Look at the slide here. Slide rotation. Here, probably see better here. Horizontal nystagmus with a very minor torsional component. Characteristic of peripheral nystagmus. Third feature can be explained by Alexander's law. Don't worry about these names. But it says that the velocity of the nystagmus is greatest when one looks at the quick phase of the nystagmus. Now you know that the quick phase in our previous video was towards the left side. So we'll see what happens when the patient looks at the left side. Center, right side, towards left side becomes really prominent. So that's the Alexander's law. Finally, peripheral vestibular nystagmus can be suppressed by visual fixation. Now, when you examine the patient, when the patient looks at your pen or finger, the nystagmus of peripheral type will be suppressed, and therefore it may not be that prominent unless it's a real acute situation. When you see the patient after about 3 days, it may not be that prominent. If you remove the fixation by special glasses like pencil glasses, or you have some other glasses, we'll show them later. When you wear it, the patient can't fix onto whatever the target, and the nystagmus will get really prominent. It seems here nystagmus is not prominent, and once you put it, it becomes prominent. This can also be demonstrated by video, for instance, which is a very good way of putting this. Once you put it, of course, there are a bit of magnification, but in addition, the nystagmus itself. So now we know peripheral vestibular nystagmus has 4 characteristics. It's a jerk nystagmus. It's a mixed horizontal torsional nystagmus. The velocity becomes greatest when you look at the fast phase, and it can be suppressed by visual fixation, and therefore you need to remove fixation when you examine. This you may not do regularly, but these 3 features are more than enough to diagnose. You can see the nystagmus. The last feature is to be special glasses. Okay. In contrast, central nystagmus. In contrast to jerk nystagmus, you may have pendular or other waveform. This is the pendular waveform. Okay, please note the waveform. It's not jerky. It's sinusoidal. If you will go with the video, nystagmus. And in contrast to mixed horizontal torsional pattern in peripheral, you get pure horizontal, vertical, or rotated nystagmus in central cases. So you have pure rotated nystagmus. You can have pure downbeating, pure horizontal, or pure nystagmus. We know the velocity the peripheral ones conform to Alexander's law, and the central one doesn't conform to Alexander's law, and central ones will not be suppressed by visual fixation. So those are the features to differentiate central causes from peripheral causes. Okay, with that we complete skill 1 that comprises examination of nystagmus. That comprises spontaneous nystagmus and gaze to nystagmus. Gaze is you are looking toward one side. You know the importance of looking on one side by now. We just go to the other part and then do the demonstration. Now we know peripheral vestibular nystagmus and central nystagmus. The second part of the skill 1 is, you can look at your handout also, it's there. Eye movements. Okay, the differentiation. So normal eye movements in peripheral, abnormal eye movements in central. So we have two clinically important central control eye movements in this scenario: smooth perceive and saccades. So what do you mean by smooth perceive eye movements? Like when you follow a pen or something, slowly and smoothly, the eyes will move and follow laterally. So yes, upwards and downwards. Both legs. Very smooth. If you see this patient, she had a cerebellar problems, followed snake bite. She can't follow the target. Smooth eye movements are broken. Broken smooth person. That is center. Second, when you look at the target quickly, alternatively. Patient can nicely focus on the target. Whereas in this clip, doesn't focus, right? So it comes back. It's hypermetric or overshoot, like you cerebellar examination. Okay, I think we'll move on to the skill 1 demonstration. Dilum is going to do that. Over to Dilum.
Mic's on. Mic's on. Okay, the subject should be seated at comfortable distance. And I'm going to show you how to check for the spontaneous nystagmus. The chin has to be 90 degrees to the neck. Okay. This is which we call the primary gaze. And ask the patient to look at your finger and observe for any nystagmus. Okay. Right. So this is the spontaneous nystagmus. And then I will show you how to check for the gaze epoch. So you go horizontal planes, 45 degrees to each side, right? Like this. And hold it for about 4 to 5 seconds. Yeah. Check for any nystagmus. Go to the right. Another 4 to 5 seconds. And the vertical plane. So why it's 45 degrees? It should not go beyond the visual fields. Otherwise, you induce a physiological nystagmus. Right? So that's the gaze you want. And then the smooth persons. So ask the patient to follow your finger, follow my finger. And the eye movement has to be smooth and conjugated and smooth. So one side to one side takes about 4 to 5 seconds. You can do it upwards as well. And when you are going down, you have to sort of lift the eyelids. Otherwise, the eyelids will going to follow and you can't see the cornea very well. Like, okay. So that's the smooth persons. And then the saccades. So I use a pen and a finger for my convenience and for the patient's convenience. Keep it for about 30 degrees from the midline, pen and the finger. So look at my pen and the finger. and the base. Finger. And with the vertical plane, we have pen and the finger. The pen, finger. So right is, sometimes you can use left and right, but the patient's right is my left. Likewise, you can confuse the patient. So use a pen and a finger for the convenience. Should I demonstrate the microphone?
I'll do it.
Yeah, please.
No. Sorry.
So this is micro goggles. Put them on. This has a magnifying glass, right? This is glass powers. You put them on. Okay. And then the situations of peripheral nystagmus, this is one of the magnifying, right? Anyway, this is magnifying glasses. You can see the eyes clearly. I'm going to circulate it among you so that you can have a closer. Okay, right. Right. So see.
You have just taken.
Okay. Now we come to second skill, head-impulse test. Very useful test to detect peripheral vestibular dysfunction. We demonstrated recently, 1988, by Professor Michael Herman. Has a very good specificity and positive predictive value in detecting peripheral vestibular dysfunction. So, yeah. So you know about vestibulocular reflex. Lasha has nicely demonstrated or illustrated the pathway involving vestibulocular reflex. There, when you turn your head towards one side, the eyes will turn the opposite side. That's a reflex, normal reflex. So we check the integrity of the sense vestibulocular reflex by doing a head-impulse test. Here, the patient is asked to look at the patient's asked to look at examiner's nose and fix the eyes there, and then the examiner thrusts the head with a little angular movement to see what happens. You see the normal response. Patient fixes on the examiner's nose and the thrust. And the eyes won't move. The patient can keep the eyes focused onto the examiner's nose. That's a normal test. Patient will keep the eyes focused when you thrust the head. But when it's abnormal, the eyes will deviate to the abnormal side with the thrust, and it will come back with the compensated second. Happens in seconds, like in this video. Yes. That's abnormal on right side, normal on left side. So again, abnormal on right side, normal on left side. Abnormal on right side. She has right-sided vestibular failure. Probably I'll just zoom that and show you. Yes. See clearly. Very useful test. Okay, so you know, are you comfortable with this slide now? How to differentiate acute severe vertigo, acute peripheral vertigo, and acute central vertigo, peripheral nystagmus, central nystagmus, normal eye movements, abnormal eye movements, head-impulse test positive, head-impulse test negative. So we go to the demonstration. Head-impulse test demonstration. And after that, you can examine each other and practice the skill. This is a very, very simple skill.
Okay. Again, you have to mics on. Mics on. Again, you have to instruct the patient. So you're going to hold the patient's head and flex a little bit, okay? And ask the patient to look at the nose or in between your eyes. And to compensate, you have to go a little down, right? And then you are going to give a thrust at 10 degrees each side. Those are random, like unpredictable ones. And you have to keep the head for about 2-3 seconds to see. And the patient should be able to compensate and fix the gaze. But the abnormal side, there will be a destabilization, right?
That's okay. Thank you very much. Thank you very much. So I think we can take about 5 minutes or 5 minutes or 10 minutes maximum to examine on each other, right? So just change the chairs, direction, and then start from the beginning. Start from examination of nystagmus first, not the head impulse first. Not the head impulse first. Start from the nystagmus. Check for spontaneous nystagmus, check for gaze evoke nystagmus, then eye movements, smooth pulses again, and then head impulses. Your handout shows what to do clearly. Spontaneous nystagmus.
This group or so I will get this join this group. Just building on the it has to be you have it. $15 degrees maximum. Did you do it or did you do it?
I think now we can move on to the next step. That is the multiple source. Now, before going to multiple source, we need to know what sort of diseases that we are dealing with in multiple source and vertigo in general. So, without the knowledge of the disease labels, we can't go further. So, for that purpose, I have just put a table to give you certain diseases that we make diagnosis about. First of all, you look at this one, benign paroxysmal positional vertigo. It's a very common condition, and we'll see the characteristic in a minute, but that's one of the diseases. And Meniere's disease, where there is increased fluid in the inner ear, high drops of the lymphatic set. You can get fistula in the lymphatic area in the inner ear. And you can get dehiscencies like superior semicircular canal dehiscence syndrome. Again, a very recent diagnosis. As recent as 1980s by minor. Also, it's another condition. And labyrinthitis and vestibular neuritis, they typically present just like in the previous presentation, acute single episode vertigo. The difference between, as I mentioned, hearing. Labyrinthitis, your hearing is also good. But in vestibular neuritis, hearing is present. Midway associated dizziness and central causes, CVAs and other space of conditions and other cardiac conditions, all central causes. So those are the disease diagnoses that we have. How do you come to diagnosis is by way of history and examination and investigation we will look in depth. But more importantly, history and examination. That will give you more than 90% of the time a correct diagnosis. So that's why your overview, the sheet that we have given to you, with all the features you generally ask in history and what examination will do is important. But for this table, we have just chosen a couple of salient points to concentrate these characteristics here. The list goes on, but concentrate on this bit first. So those are the features of the vertigo itself. About the nature of the vertigo, for example, to take BPPV, Meniere's, and perilymphatic fistula, you get three clusters for typical rotatory illusion of movement. If you go towards the end, in central causes, cerebral perfusion may be low, it may be more of the lightheadedness rather than too red. You can also get that, but mostly it's a lightheadedness. And the onset of the symptom, okay, very acute in most of these conditions, except for midway, maybe gradual onset, variable onset in central causes. And severity, it's very severe in peripheral causes, and variable and even low in central causes. Duration, very important discriminating point. In BPPV, it's less than a minute, very short duration of the episode. Meniere's, it may last for hours. Perilymphatic fistula from seconds to hours. And labyrinthitis is typically days. They are episodic vertigo. They take days for the patient to recover from the symptoms. variable in migraine and other conditions. And recovery, again, very rapid in peripheral cases, especially BPPV and medians. Variable in peripheral fistula, very gradual in vestibuloneuritis and migraine, and variable in cell. So as you can see, vertigo itself, nature and the pattern and the characteristics, how it's set on, how long does it take, can help in coming to reasonable discriminatory points. And to take the next step, there are associations that will help further. For example, BPPV typically related to head posture. And tinnitus, oral fullness, and tinnitus, oral fullness, and sound sensitivity, hearing loss. These are features of cochlear damage. So, Venus is typically having those features. In BPPV, you don't get those, as in central causes. If there's loss of consciousness, that's a feature of central. You don't get loss of consciousness in BPPV or Venus. Turios effect refers to a situation where loud noises cause symptoms and mistakes. And that is typically seen in superior semicircular canal lesions and also pediatric fistula and some illness patients. Light sensitivity typically in migraine associated disease. And there's head trauma, history of trauma to the head, BPPV and pediatric fistula or lesions, they are common diagnosis, mostly lesions. And this is very important, focal neurological findings. You get focal neurological findings, it's not going to be BPPV. Because there's some problem. Sometimes you can get transient changes in migraine associated diseases, but mostly central causes cause focal neurological signs. So these are the characteristics that we use. These are the features of vertigo episode. These are the associations. Right. So with that summary, let's move on to three common conditions: BPPV, Meniere's, and migraine associated disease, as the three important ones we see day in and day out. Out of the three, if you take Meniere's disease, you get a lot of ear symptoms like tinnitus, fullness, sound sensitivity, hearing loss. You don't get that in the other conditions. You get photosensitivity mostly with migraine, with headache. You don't get that in Meniere's. And trauma to the head and positional BP. So, you take a situation, 56-year-old female with brief episodes of vertigo lasting less than a minute, on turning the head on the bed for last 2 weeks. So what sort of diagnosis do you consider first? BPPV. So that's very common. In fact, that's the usual situation also. Now this is a summary table of 17,718 patients. And the commonest diagnosis is benign paramuscular positional vertigo. So how do you come to the diagnosis of this? What is the pathophysiology? How do you treat it? So that's the part or the focus of this part of the presentation. So this is what happens in BPPV. Familiar diagram again, semicircular canals and influenza saccule, and we discuss about the autoconia, calcium carbonate crystals in the macula of the uterine and the saccule, right? So that's the normal place for them. But sometimes these particles become loose, maybe after a trauma, maybe after viral infection, autoimmune insult, or idiopathic, we don't know whether. And what happens is that they drift or dislocate into a different place. This is not the normal place for them. And if you look at this anatomic diagram, you can see why it is more common to get posterior semicircular canal problems because of the anatomic location. And superior ones tend to get self-corrected anyway, and you can get lateral dislocations also, but not as frequent as posterior semicircular canal being deep. So when they are in this abnormal place with the fluid mechanism, when the head is turned to that side, the patient is going to get abnormal sensation until the particles settle. So that's the pathophysiology or the canalary dialysis theory of BPPV. So how we diagnose this? With Dick's fold pipe test. So that's the next skill that we are going to learn. So how I want to do that is I will follow, we'll take you through the line diagrams now, and then you will see what actually is happening. And then we will demonstrate that on table here. and then you can practice it at the end. That clear? So, and also we have given you a sheet of checklist, and it shows the steps. There are 7 steps. The last step being repeating on the other side. So there are actually 6 steps on one side. So just follow along and see how this is done. First 2 steps. Here is here 2 steps important are instructions and standing beside the patient. So instructions, what sort of instruction you are going to give to this patient? You will say that you are going to turn your head and put yourself down, and you are likely to get symptoms. And if you become sick, don't worry, you're not going to fall. Reassure the patient because it's very important, it's very frightening for them to have that. And maybe you should have a bucket ready because if the patient comes want vomit, it should be prepared. And also, the patient should not have any restrictive neck problems. So we'll turn the head now. And also make sure the patient has someone to accompany them after the procedure. They can't drive themselves. They may not be able to. So those are the preliminaries, both disqualified test and the release management. All these pharmacological question things. So that's the instruction bit. And then you stand beside the patient. First 2 steps. Next 2 steps now. Correct seating position and head turn 45 degrees. Now, you can see that in this diagram, the head is turned 45 and you have to see the position in a correct position. What is the correct seated position? Correct seated position is when the patient is laid down, the head needs to go beyond the couch. So you need to position the patient so that when the patient is down, it should go beyond the couch. That's the correct seated position. Very simple. And you need to judge, judge roughly where the patient should be. You can't put the patient and sit the patient after that because when you put the patient, they will become symptomatic. So judge where they should be seated first. So seating position and head turn. Those are the next 2. Last 2 steps. You need to get the patient to lie down very quickly, and it has to be going beyond 30 degrees, the horizontal level. 30 degrees below the horizontal level, and we are looking for a nystagmus. So instruct the patient the first step that they need to keep the eyes open because they are looking for a side mid-eye. So those are the 6 steps. So let's summarize them. Instructions, I told you about. Stand beside the patient, head turn 45 degrees, correct seating position, lay flat quickly in smooth movement, 30 degrees below horizontal level, and you are checking for the nystagmus. Lastly, you need to repeat that on the other side. It may be useful to ask which side the patient roughly knows whether they are symptomatic on, and start on the normal side first, and then you move on the other side. Repeat on both sides. This is the nystagmus we are going to see. So just see the nystagmus and see whether you can find any characteristics of this nystagmus. I hope you appreciated these features. When the nystagmus started, it didn't start immediately. There was a latency. And then it has a geotropic or towards the ground and the corrective upbeat, torsional. And it becomes worse initially, crescendo, and then decrescendo. So those are the features. You can see that again. Latency, geotropic, torsional, crescendos, and decrescendos. There are 2 additional features. When the patient is sat up again, they are going to have a reverse and also recurrence of the symptoms and the vertigo. And if you do it again, it fatigues again. So if you have all these 6 features, that's a typical TBD nystagmus. Then you can diagnose. If you don't have those, think about other possibilities and you can do the neurological examination. Right. So it's time to demonstrate this skill now. So Damin is going to show up here. So let's first going to demonstrate the correct seated position where the patient, where the examiner should be. The instructions are given. The head is turned to 45 degrees. Then we need to lay the patient down in a smooth, quick movement, and the head should go below 30 degrees, as you can see. And the eyes are kept open, and we are looking for a nystagmus. We need to wait for a couple of seconds, at least 30 seconds, because of the latency. Then you will see the typical nystagmus that we discussed. Okay, is that clear? The disqualified test. So what is the treatment? Anyone knows? Yes, the treatment. So we need to now do some form of analytic repositioning, commonly done on this treatment. There are several others, but at least has been proven, and that's what we're going to show today. So again, like previously, I will be showing you some line diagrams and then demonstrating, and then you can practice. So this is the diagram. From the seated position, there are 1, 2, 3, 4, 5 steps. The first step is actually like a resolve like this. So let's take this in detail. Right. In the seated position, we need to use the instructions like before. Seat the patient in the correct seated position. Enter the 45 degrees of the side, wait for 30 seconds. That's it, very simple. And in this situation, it may be easier for the examiner to come to the end of the couch, because now we have to turn the head now. It's slightly difficult from the side. So come to the end now. And that's the first step, so seated. Second step, or actually the first stage of movement is like this also. Get the head down, 45 degrees turn, 30 degrees below horizontal plane, and wait for 30 seconds. Next, we need to turn the head 90 degrees now, towards the good ear. We need to turn the head towards the good ear in 90 degrees. And we wait for 30 seconds. When the patient becomes symptomatic now, at any point, we need to wait till they become better before we proceed to the next step. Now we need to turn another 90 degrees. But before doing that, it will be useful to lie on the hip and the shoulder on the good side. And then turn the patient's head towards the good ear 90 degrees. And wait for 30 seconds. Just like that. Fourthly, we can get the patient up now, seated position, without changing the head position. So we tell them, don't move the head, just keep it the way it is, without changing relative to the front. And then wait for 30 seconds. And lastly, you can flex the head towards the chest, chin towards the chest, and wait for 30 seconds. So let's look at it again. We start with the seated position, just like before. Do the just like this whole fight, but you don't have to do it very quickly now. And slowly, and then turn 90 degrees, another 90 degrees with the help of shoulder and hip movement, seated up, head cancel. Is that clear? So we'll demonstrate it again now. Instructions given, correct seated position, head turn 45 degrees and wait for 30 seconds. Just like this whole 5 test, head below the horizontal level 30 degrees, waiting for 30 seconds. Then 90 degrees turn, wait for 30 seconds. Then we need to do another 90 degrees. But before that, it will be useful for the patient to lie on the good side, shoulder, and the hip, like so. You can at this point get an assistant to help you, because some patients are really obese and they can't do that on their own. And then you do the 90 degrees, and now the nose should be pointing towards the ground. Wait for 30 seconds, and next, the patient has to be seated without changing the head and neck positions. 30 seconds. Last bit, flex the head and wait for the result. Right. So now it's time to practice the skill. Second session of practice. For this, we have prepared 4 couches at the corners, and you will be given color codes. Is that right? You will be given any color codes. Okay. So the pink ones can come over here. Green there.
Yeah. How do you do that? This first.
Yeah, sure.
The height of the person and know the weather, right? So this is too much. Yeah, that's sure. You want to do it first or do it after? Yeah. So decode back this turn the head to 45 degrees. Okay. And you will do one quick movement. Before that, we didn't ask the patient with the neck pain, right? Okay. So you need to get my eyes in between my eyes, right? Okay. Wait for about 30 seconds because there's the latency also there, right? And the patient will complain of vertigo at this point. If it is the affected side, but if it is not, we'll do it the other side as well. Okay. Right. So, and the F-days is the same thing. At this point, I go to the head. Same thing. You know the affected ear. So affected ear. So you turn the head to the affected ear, 45 degrees, and wait for about 30 seconds. And this time slow movement. Same thing. Okay. And at this point, the patient will definitely complain of vertigo. And wait for 30 seconds. Yeah. I use a chair, which may have the other way. It will be a bit difficult to get the right angle. So from 45 to 45 here, or to the 90 degrees, I'm going to turn the head. So keep there for about 30 seconds. At this point also, patient will complain of a headache. Sorry, vertigo. Okay, there will be vertigo. Sometimes they vomit. And could you bend your right knee for me? Yeah. Okay. If you using the correct the maneuver, you can turn the patient, even if it's a obese patient with a one hand. Patient will be unable to turn by themselves as a head is restricted on using a shoulder and turn the patient there. You don't move the head. You don't move the head. Yeah. The last bit, you have to turn there, so the nose will be pointing exactly to the ground. Okay. So wait there for about 30 seconds. You come to a side because sometimes they can fall off from the bed, right? So you need to come to the free edge of the bed. And then come here, ask the subject to sit down with the maintaining the head position. And with one movement, you have to bring his chin to the chest. And hold it for another 30 seconds. Right. Right. Good. And you can practice that. Very slowly, it will be like sometimes we will do it together. Yeah. At this point also people remember. The body tension and the head position has to always try to go together so that you don't have weight after that. Yes, same. Finally, when we reaching the default back.
So you have to go on the second.
So when you identify the affected site, you know yeah. The patient is depend on that side, the patient will give the intest is like this. Yeah. So real patients like try to hold the bed immediately. Because they feel should we that depends. There are possibly patients should not be like
Slide like classified.
Yeah.
Can we come to the, can we take the seats now? Can we take the seats now, please? A couple of announcements before we proceed. Couple of announcements before we proceed. One, I think there's a change in the lunch time. After this session, you are supposed to go to the next session that you are not in. And after the skills, all the skills will be having the lunch. That's the plan. The organizers have informed us. So soon after this one, we'll be starting the other group. The second thing is about the entry. As you said, as you must have witnessed, there are subtle variations among the examiners how they do it. But the four principles are given, and those are really core. The others we can change very easily. And also, after the procedure, post-FLE, we give some instruction to the patients. Because now we have repositioned the autophonic delivery to the correct state, we don't want them to get back to abnormal state. So we ask the patient, try and keep the head upright without changing too much. In Eastern cultures, we do all the heads. When we talk, we swing the head like it can be a dance. We ask them not to do that and try and keep the head keep it still. Especially for patients who are getting the symptoms again and again, can get recurrent BP. And we ask them to sleep semi-recumbent position with like an armchair or something like that if they are really symptomatic. And also to avoid sleeping on the affected side for a couple of days because it will help things to settle down. And after about a week, we want them to sit on the affected side because that is to try and increase the compensation of the vestibular system. And you can repeat the at least maneuver as much as many times as you like. But if the patient is having symptoms, especially with abnormal nystagmus, you will think of other diagnosis and start investigating also. Right? So, having said that, I think we have come to the end of the presentation. A couple of announcements. I will be distributing the links to the website. You can when you visit the website, you'll be asked to get registered. It's a free registration, obviously. You need to create an account. And all slides and presentations are available there. You can see them. And also the webinar. As I told you, we are live streaming this one. The webinar will also be available there. So you can watch that later. This is how you will see when you log in. If you click this link, you can go to the webinar and click this link. Like that. They will ask you to log in with this thing, or you can create a new account. This is your first time here, you can create a new account. And you will see when you log in, features like this. The objectives, agenda, and procedure checklists, and lessons, the presentations, and when you click on those, it will be the slideshow, and you can download it like that, and then open it and proceed. Right. This is how it will run, right? So now you get the idea, right? So now we have about 5 minutes more for question and answers. And also before you leave, we want you to fill the feedback form. It will only take 1 minute. So that's the name of the feedback form anyway. So don't take more than that. Just take 1 minute and fill it up. Next week we are us. We help us to improve this for the next session. Right. Any questions you want to ask?